Hi, good afternoon. Otis Toussaint here, working for the Office of the Surgeon General here in Washington, D.C. I'd like to introduce you and bring you on to our current panel here at the live stream and the live AUSA conference. Who do we have and what are we talking about today? We're talking about today the COVID-19 panel, and it's comprised of two personnel. Colonel Jan MABY and Mr. John RESTA. And I'd like to introduce you to both. Hi, everyone. How y'all doing?
Good afternoon.
Excellent. Thank you.
Awesome. Awesome. And so I want to say, first of all, thank you for taking the afternoon to come and talk with us, talk to all the viewers, especially in regards to the MEDCOM's response and the MEDCOM's position regarding COVID-19. And so I'm thankful to have this illustrious panel with me today. And of course, I've got the two personnel, but I'd like to have you, ma'am, go ahead and introduce us yourself and Mr. RESTA as well.
Very good. Good morning and thank you. And thank you for those who have joined us virtually. I appreciate your interest and support in this very important topic. I want to begin today by recognizing all those hardworking heroes that are keeping America running in the face of this pandemic. And I'd like to thank our soldiers and their families, my fellow public health providers, and the public health emergency officers who have been inspirational in their response to this pandemic, and for their support in maintaining military readiness and protecting our nation as we battle against coronavirus COVID-19. As you heard, my name is Jan MABY, and I am the Chief of Public Health for the Regional Health Command Atlantic, the largest health command in Army medicine. The Atlantic region includes all Army medical centers, hospitals, and clinics east of the Mississippi River. In a nutshell, I oversee the public health activities that fall under Army's medical treatment facilities in the 26 states that make up our region. We have been involved in the many facets of the military's response to this pandemic, in line with the U.S. Army Public Health Center guidance. I am joined today by Mr. John RESTA. Mr. RESTA serves as the director of the U.S. Army Public Health Center, where he is responsible for overseeing the activities of more than 1,000 scientists, physicians, engineers, industrial hygienists, veterinarians, and many other public health specialists. He simultaneously serves as the acting Deputy Chief of Staff for Public Health under the Office of the Surgeon General, representing the U.S. Army Medical Command, Commanding General on all public health, wellness, environmental health, and veterinary services. Army public health activities establish practical measures for the prevention, maintenance, and restoration of health in Army populations through the anticipation, prediction, identification, surveillance, evaluation, prevention, and control of diseases and non-battle injury. Public health is a major enabler for Army readiness and a major component of force health protection and its application throughout all Army activities. If I could have the next slide.
Let's go ahead and put the slides on, actually, ma'am. Here we go.
And we're on slide 2. During the oath of enlistment, soldiers swear to defend the country against all enemies, foreign and domestic. But few envision the enemy would be a covert embedded infectious disease. However, this is not the first war, so to speak, against an infectious enemy. And the COVID-19 pandemic is not the first time the military has faced a virus with significant impact to military readiness. During the American Revolution, the colonists facing the British also faced an invisible enemy that threatened to wipe out the new Continental Army, the highly contagious virus smallpox. Smallpox like severe acute respiratory syndrome coronavirus 2, also known as SARS-CoV-2 or COVID-19, is a disease that is spread by face-to-face contact and by those infected who are already contagious before experiencing any symptoms. George Washington recognized, as smallpox spread across the American colonies, that if his soldiers were to continue fighting, he would need a plan to defeat this dreaded disease. Washington wrote, "We should have more to dread from the disease than from the sword of the enemy." Indeed, the overall impact of smallpox, combined with the Canadian winter and the invasion of Quebec, was significant. To combat this threat, George Washington, who had already adopted many public health principles, began isolating those infected with smallpox to stop the spread of disease and quarantines those exposed. And in 1777, he begins the first mass military inoculation in history when he inoculates the troops against smallpox. George Washington understood the need to protect the force, to protect the nation. Many of the public health and medical challenges of deployment have continued since George Washington rode out among the soldiers at Valley Forge. Personnel still require safe food and water, protection from the elements, properly located latrines, and protection from diseases and insects. The next slide, please. In a New England Journal of Medicine article published in 2012, Dr. Fauci noted, quote, "Among the many challenges to health, infectious diseases stand out for their ability to have a profound impact on the human species. Great pandemics and local epidemics alike have influenced the course of wars, determined the fates of nations and empires, and affected the progress of civilization, making infections compelling actors in the drama of human history," unquote. The characteristics of their unpredictability and the potential for explosive global effect is exemplified by the bubonic pneumonic plague pandemic of the 14th century, the pandemic of HIV/AIDS, and the 1918 influenza pandemic. The influenza virus was an enemy my grandfather faced in World War I when he sailed to France with the 27th Infantry Division from New York as a member of the 105th Field Artillery. As American soldiers mobilized for war in the spring of 1918, Army physicians began noticing a worrisome influenza among their soldiers. A deadly pandemic had begun with a virus that would have significant impact on our military. The virus, commonly known as the Spanish flu, took hold in the crowded conditions at the training camps and sailed with the American troops across the Atlantic. Sick soldiers could not report for training or for duty, and weakened soldiers performed badly. Low unit morale likewise undermined effectiveness. Additionally, the conditions in the camps, battlefield, and trenches further the spread of disease. In the end, influenza and pneumonia killed more American military members during World War I than did the enemy's weapons. Next slide, please. Some may argue against using the war analogy in our fight against COVID-19, but many analogies apply. COVID-19 is deadly, and leaders are often required to make rapid life and death decisions under intense pressure and with incomplete information. The scale and complexity of the situation is tremendous, and the stakes are high. With the assistance from the Army Public Health Team during the great influenza pandemic of yesterday, and in the face of today's infectious diseases, such as malaria, Ebola, and COVID-19, the mission goes on. As we continue to train, the focus has always been and will always be the safety of our recruits, our soldiers and their families, and our civilian and contractor workforce. The Army has adapted requirements to maintain readiness in the face of this embedded, unseen infectious enemy. And public health is central to developing the response to allowed continued operations. And to discuss our approach, I would like to turn the presentation over to the Director of the of the Army's Public Health, Mr. John RESTA. Next slide.
Thank you, Colonel Mabey. Good afternoon, everyone. Good morning for those of you who are on the West Coast, and good evening for you that are calling us in from New York. Here's a current outlook slide. This slide, the data on this slide is about 2 weeks old. The situation actually has worsened in those previous 2 weeks. Globally, the SARS-CoV outbreak remains high. It is plateauing, so it means it's flattening out, but it's plateauing at a highest level that we have seen, and certainly over some areas where it's been the highest we have ever seen. Currently, globally, the epicenters, that means those places where the rates are the highest, are Asia and the Americas. And in the Americas, we mean both North America, predominantly the United States, as well as South America, in terms of countries like Brazil. In Asia, India remains a hotbed for COVID outbreak and are continuing to have concerns and problems. In the United States, we are reaching a new plateau. We have current hotspots in the Midwest, Upper Midwest, and Northern Plains. Wisconsin, Minnesota, North Dakota are examples, but we're already starting to see signs of increasing rates in the Mid-Atlantic region, in the lower central Midwest, and in various other places in the Upper West and the Northwest. You can see that in the lower right here, where case rates are color-coded: green, yellow, orange, and then red being the worst case. And so you can see that the map is starting to turn red within the United States. If you get the next slide, please. Within the Army, we have been tracking case rates, confirmed case rates for this since the end of January. We have been pretty fortunate within the Army, and mostly because our population is young and healthy. Typically, they basically incur a COVID illness. Either they are completely asymptomatic or mostly mildly symptomatic. 89% of the confirmed cases we have detected due to screening and surveillance during our initial entry training, basic training. We're not seeing them. It's not like they're falling ill. We're just detecting them due to our screening. We see occasional clusters, which would be expected in a worldwide pandemic of a respiratory illness, especially in places where large groups gather, congregate settings, things like barracks, large-scale formations, sometimes recreational activities like parties, and actually choir practice at the church. Most of the spread comes from the community, where permanent party who will go off post, go home, bring it back onto post. Sometimes we just fail to detect via testing. The testing technology that we have is not perfect, is not foolproof. And so there's always a case and interest in whether or not it's a false negative and or a false positive. And lastly, one of the big reasons that we're having problems with our case rates is what we call pandemic fatigue. Sometimes you'll call it pandemic denial, where we have non-compliance with what we call non-pharmaceutical interventions. Staying out of crowds, staying home when sick, wearing a mask all the time, washing your hands, and basically getting tested when it's appropriate. As of 13 October, as of this morning, our rates have gone up since this 29 September. We now have 14,239 soldiers have been infected. 124 have been hospitalized. We're not having any threat to our treatment capacity. We are still fortunate that even now, October 13th, we have only had 8 deaths. And that sounds a perverse way of saying, because in those families, those 8 deaths are tragedies. We have not had any deaths within our active component. All our deaths have been in reserve component soldiers who had been mobilized in many cases to help fight this, or in some cases just had been on regular reserve duty on the weekends and the like, or had been at home in a reserve status, an IR status, and the like. If you look in the lower right-hand box, you'll see the amount of testing that the United States Army is doing. United States Army, as well as the broader Department of Defense, has a very aggressive and active surveillance and screening program where we are testing soldiers, sailors, airmen, Marines for the presence of this illness, even without them displaying any symptoms. We're trying to do that to control the spread within our formations. And so you can see the episodic testing that we have. Our test positivity rate is around 5%. Sometimes it goes up, sometimes it goes down, depends upon where we are here. That's a measure of, are we testing enough to catch unknown infections in our population? And we think we are. We go to the next slide, please. Here's what we predict is going to happen. And we've been saying this for months, and so current events are actually solidifying and giving us more confidence. We anticipate we're going to have sustained endemic transmission. It's going to continue until such time as there is a vaccine that's widely available and widely used. And even then, it will take some time before we can knock down the rates of this. The most successful vaccines we have, things like measles, smallpox, mumps, as well as influenza. Very few are 100% effective. Polio is an example of one. Measles can be an example of one. But many of them are, mild, let's say 50%, 75%, 90%, 99.9% even. There's always a chance that a vaccine will not protect someone. We anticipate that with this. We think we're going to have sporadic hotspots and clusters. We're seeing that now. We're seeing that in Wisconsin. We're seeing that in Minnesota. We're seeing that in many towns where there's universities and colleges. We're seeing that sometimes we see that on military installations. We have increasing concern of higher rates and higher activities during the fall and winter. As more people move inside, higher risk environments are indoors. And so as people start to congregate, we are particularly concerned about the upcoming holidays, Thanksgiving, Christmas, other winter breaks and the like, where individuals travel all over the country and visit family in concentrated settings in people's private homes. We know that, for example, vacations have caused outbreaks. I read a report this morning of a 13-year-old girl on vacation with her family, infected 11 members of her family in 4 different states, just by spending a week or 2 weeks with them in a beach house. The risk associated with this is how much time you spend with an infected person, how close you are, what you're doing, and whether you're indoors or outdoors. If you're in a choir indoors practicing and someone's infected, there's a good chance other members of that choir will get sick. If you're outdoors in a park and you're not real close to each other and you're walking on a trail, you're riding a bicycle, and someone's infected, the chances are less that you might get infected from that person. The best defense are anticipating and applying the core principles of public health. We want to reinforce compliance with what we call personal protective measures. Stay out of crowds. Stay home when you're ill. Wear a mask. Wash your hands. Stay away from people who are obviously sick. Right? As we have outbreaks, we're going to need to adjust the dial. In many cases, that might mean restricting on-base installation activities, going from a health protection condition Bravo, perhaps up to a health protection condition Charlie. We're hoping we don't have to do that. We're hoping we don't have to close on-base activities like bowling alleys and gyms and the like. Lastly, what we want to really do is make sure we protect the vulnerable. Age is the leading risk factor associated with suffering a severe illness and or death from COVID. So we want to make sure that we protect our elderly. A lot of times we don't think we need to protect our elderly because we're not around old people. But in this case, we're talking about people who are over the age of 50. And so many of us, to include myself, are in that vulnerable population, and we want to do that. The impact of readiness, we think, will remain low. Most of our soldiers are very young. They're very healthy. They don't have any pre-existing medical conditions that would increase their risks. And we anticipate if they do fall ill, that they will recover rather quickly. To do that, we continue to do a lot of surveillance. And one of the areas that we're looking at is called pooled testing, where we collect specimens from a large group of people and pool them, where we might take specimens from 10 soldiers, combine them into a single pool, and only have to test that one pool. And if that pool is negative, we know all soldiers in that pool are negative. And if that pool is positive, we know at least one soldier is positive. And so we have to have all those samples then referred for analysis. There's emerging point of care antigen tests that are out there now that are being written about in the media. Sometimes they're not as good as often the headlines would let you believe. B, they're not as available sometimes as the headlines would let you believe, but they're coming and they're getting better. We in the Army plan to use them to help us with our screening, and I imagine many people will start seeing them in their healthcare providers' offices. One area that I would really like to emphasize to everybody is that while this won't reduce your risks of getting COVID, it will reduce your risks of being hospitalized in a hospital full of people who already have COVID. And that's to get vaccinated for flu. We anticipate that this is maybe the most important time ever to get a flu vaccine, because if you contract the flu and you fall ill and you go into a hospital, the chances are that many other people in that hospital will be there, but they will have COVID, which does not have a vaccine. And you could end up being hospitalized for flu and contracting COVID while you're in the hospital. We want to make sure that that doesn't happen. We certainly want to make sure that doesn't happen while we're developing, we, the big scientific community, the COVID-19 vaccine. Currently, there are multiple vaccines being tested in various stages of clinical trials. Some of them, those clinical trials, are fully enrolled, and we expect to see some of the results coming out of that in the next probably month to 2 months. We anticipate approval of a vaccine sometime in early 2020, and then hopefully we will roll that out within the Army to protect our vulnerables, to protect our soldiers, and to protect our beneficiaries. We will obviously, given supply, have to use some type of a priority, but we'll work through that. We hope that by this time next year, there will be enough vaccine for everybody in the United States to get vaccinated, given when they need it. Next slide, please. This gives you an example of what we're concerned about in terms of influenza. If you take a look at our past couple of years with influenza, you'll see that we've had these seasonal influenza outbreaks. Last year was particularly bad. The year before that wasn't as bad. The year before that wasn't as bad. All right, so we don't know what's going to happen. To date, in the Southern Hemisphere, which flu season always predates the Northern Hemisphere, flu activity was very low. We're not sure why that was. What it may be is that everyone was so concerned about COVID, they practiced safe practices against respiratory diseases, and it drove down flu. So if we continue to protect ourselves against COVID, we should protect ourselves against flu, particularly if we get a vaccine. If we get immunized against flu and protect ourselves, our chances of not contracting flu go way, way, way down. If you get over the next slide, please. And so if we take a look at where we are, we can see that this summer, COVID supplanted all influ-like illnesses in North America earlier in the spring, and continues to be the leading cause of respiratory illnesses in the United States. So we're hoping that we can keep that flu number down, because if that flu number goes up and we stack COVID on top of that, we will clearly overtake and overrun our healthcare facilities. And we'll end up having to set up field hospitals, treat patients in hallways, and potentially people could end up dying needlessly. And that's what we're trying to prevent. Next slide, please. So my takeaway and closing comments are: wear a mask. There's lots of information out there. Some of it is very good, and some of it is actually false. Face cloth coverings, masks protect you and protect others. I wear my mask to protect those around me, and I hope they will do the same for me. Practice social distancing. Put space between yourself and others, people that you don't live with. One of the common things are people are getting sick because they're with members of their family who they don't live with. They just see them at a barbecue, at a party, at a christening, at a dinner. If you're not living with someone, they're a stranger to you immunologically, and you want to make sure that you don't get sick from them and that you don't make them sick. If you are sick, stay home. If you've been around anyone who is sick, stay home. If you are sick and you stay home, we call that isolation. If you have been around someone who is sick and you stay home, we call that quarantine. At the end of the day, just stay away from people if you're sick, and stay away from people if you've been around anyone who is sick. We want you to wash your hands often and thoroughly. If your hands aren't chapped by now, 7 months into this pandemic, you're not washing your hands enough. So wash your hands. You want to make sure you cover your coughs and sneezes. You don't have to take out if you're wearing a face mask, you don't have to worry about that. You're going to sneeze into your mask. But you want to make sure that you're not coughing or sneezing around anyone. One, people tend to freak out, even if it's allergies. Two, you spread it more. You can spread COVID by talking, but you really spread it when you cough, when you sneeze. And lastly, you want to make sure that not only your seasonal flu shot, but all of your immunizations are up to date. And so this is particularly important. If you have not been immunized, if you haven't gotten a flu shot this year yet, go get it. If you have TRICARE, you can go out to the network. There's plenty of flu vaccine out there. In CVS, you can get them at Target. I get mine at Safeway. And so there's plenty of places where you can get a flu shot. And in most cases, it's actually free. In many cases, they actually give you a coupon, a $5 coupon to get a flu shot. And so I would encourage you to do it. And not only you, make sure your family is immunized as well, to include your children. Whether your children are in school or not, they are at risk of contracting influenza. And influenza typically treats children worse off than COVID has been. And so you want to make sure that your children aren't really fall severely ill due to influenza when everyone's worried about COVID. Thank you for your attention this afternoon. And I think we have time to take some questions from the audience.
We do, sir. We do, sir. Thank you for the presentation. And ma'am, thank you for the earlier presentation that you gave as well. I will go ahead and start posting some of the questions that we are already receiving as well. So let's change the viewership. Let's change it to this way. And so the first question that comes up is, I'll show it on screen. Some public health experts are warning that the upcoming fall and winter seasons could potentially be dangerous as people host indoor gatherings because of cold weather. What do you recommend people do to protect themselves with the COVID-19 this winter?
This is a difficult situation because most of the time you're dealing with members who are very close. You're dealing with your family, your loved ones. First, stay out of large crowds. Even if you're from a very large family, stay out of any large crowds. Simple as that. The more crowds you stay out of, whether you're indoors or outdoors, the lower your risks are. If you can stay out of any place where there's people that don't live with you indoors, restaurants, bars, movie theaters, any other place, your risks are lower. So indoor spaces are at greater risk than outdoor spaces. Crowded spaces, both indoors or outdoors, are at greater risk than less crowded spaces. And I think everybody in America is going to have to make a decision of what do you do for Thanksgiving? What do you do for Christmas? I come from a very large family, and at Thanksgiving, usually the Saturday after Thanksgiving, all of our family gets together, and sometimes it can be greater than 50 people. And we're all talking about that now. What are we going to do about that? And we'll come to a decision. But if you have to go someplace, if you have to be indoors, wear a mask. You might be uncomfortable. You might be teased by your family. You might be teased by your friends who either don't believe it or are just tired of it. But I've seen this illness within my family. My daughter's fallen ill. My sister's fallen ill. My sister-in-law has fallen ill, was hospitalized, and she's recovered. And now I have a niece who's a nurse who's fallen ill. I know at least 3 individuals who have died from this disease. This is not trivial. It's not a hoax. It's real, and it can really affect you. And so you don't want to make a decision that you'll regret, or perhaps your family will regret because you're no longer around.
Thank you, sir. Let's ask, and then we have a second question. The question is, any of us who are familiar with recent events can see that COVID-19 It's affecting all members of society, including individuals in the White House, as well as the military. Are you concerned that recent COVID-19 diagnoses are affecting military readiness?
No, I'm not. When I say concerned, I'm concerned about everything. Public health people worry about everything all the time. But do I think that they're affecting military readiness? No. And the reason I don't think is that, one, our leaders have been very concerned about this since the beginning. Our leaders understand risk. Our leaders have requested, have solicited, have asked, have sought, have demanded information. Sometimes I have to answer the same question a dozen times in one day because people want the information to make decisions. And then our leaders are willing to make decisions to change things to reduce that risk. I think recent events where we've had senior members who have contracted COVID, and then we've had senior members who were then exposed to those and have subsequently quarantined themselves, show me that our leaders take this seriously. They're all able to continue to work. They have effective communications. They are still sending taskers and emails and RFIs, even though we know that they're quarantined. And so from our perspective, it hasn't affected our readiness at all.
I would like to add, sir, that the soldiers also take their duty very seriously. And when the senior leaders get the information and adapt and adjust what is required to be able to train and maintain readiness in a COVID environment, the soldiers that make up their teams follow that guidance and are in line with maintaining a strict COVID posture. And so, as Mr. Resta said, you know, as public health leaders, we worry about all the things that can impact the soldiers' ability to fight. But I wouldn't say that this is out of line from the other things that we bring to the table, such as the other infectious diseases I spoke of, or latrines or food and water. Over.
Thank you. So the next question is, how is the Army Medical Command assisting local and regional commanders?
We are fortunate, and actually we have one with us, Colonel MABY is one. We are fortunate. We have a network of individuals that we call public health emergency officers. And at every medical treatment facility, there is a named individual, typically a medical provider like Colonel MABY is, who is trained on how to assist and manage a public health emergency. These are the silent heroes of this outbreak response so far. And so what we are doing from the command is to provide them information, assistance, guidance, data, handouts, health education, videos, and the like. They then advise their senior mission commanders on what steps to take to protect that specific installation. They're the ones who advise the commanders on what public health, what health protection condition, HPCon, that installation should adopt and what that means. And so we have our public health emergency management program manager is Dr. Patty Garcia, who is on my team up here at headquarters. And she sends out emails. I think we're now down to 2 emails a week, but we provide all this guidance out, and they have some of the best questions, some of the most energetic debates, but it is a community that has basically, I think, protected the Army. And then I'll defer to Colonel MABY from her perspective as a FIO, how that's helped her.
Thank you, sir. So in many aspects, public health is a local issue, whether it's your local community public health leaders in the civilian sector, or certainly your local issues on your installation. And then even you could drill it down on that installation, depending on your mission, your public health needs may also differ. And so the FIO is an installation level public health advisor to work with the garrison commander to help shape the public health response on that installation. It's a situation that the Army anticipated a need for, but I don't think ever really expected it. And so there has been guidance, and every installation has a FIO assigned, but it was often a secondary duty and in the background. And COVID has really brought the importance, as Mr. Rester said, of this member, civilian or military, the importance of this person to the forefront as a core member of the public health response team. Over.
And the next question is, how did service members and their families get the most up-to-date COVID-19 information?
I think this is a very important question, because one of the challenges with COVID-19 that I know I've struggled with is the amount of information that's out there and whether or not it's accurate. I am troubled and scratching my head often of how we counter not only incorrect information, but I think that there are actually misinformation that is out there. So trusted sources of information, one is if you go to the U.S. Army Medical Command website, it will link you to the U.S. Army Public Health Center's website, where you will get the up-to-date information on COVID that is available. The Centers for Disease Control and Prevention is another good site. Oftentimes, however, people, and I'm looking up the telephone number so that I can get that to you, but oftentimes the people are tired of looking things up and just want to talk to someone. And so the Army Medical Command has a program called the Army Medical Readiness Assistance Program, and they have established a COVID-19 hotline that is manned 24 hours a day, and it can be reached by calling 1-800-984-8523. Overseas, callers can dial DSN 312-421-3700. And if you have an unlimited cell phone plan and you don't want to wait on an 800 call, it's area code 210-295-3700. And these individuals can help you, point you to resources, point you to care if you need to find a physician, or answer any questions and get you in touch with an expert.
Ma'am, did you want to add to this question?
No, sir. Thank you.
All right, no problem. Let's add. So the next question that we've got here is the Army working on a vaccine for COVID-19?
Army scientists from the Walter Reed Army Institute of Research and the have been actively working on coronavirus vaccines for, I think, well over a decade, and are engaged in now working on a vaccine for SARS-CoV-2. At the same time, the U.S. Army Research Institute of Infectious Diseases is collaborating with multiple vaccine studies that are out there by AstraZeneca, Johnson & Johnson, Moderna, and several more. I apologize, I don't track. I think there's about 7 or 8 vaccine candidates that are out there right now, working with industry, academia, and the like, all through the National Institutes of Health and the National Institutes of Allergies and Infectious Diseases. And so Army Medicine Research is leading some of this efforts. We're supporting all of it. And Army Medicine is also helping to assure some of these clinical trials so that we get enough people tested to include military populations. And so we're very proud of that, in that we're helping, like we have helped with all public health emergencies since the Revolutionary War, where we helped lead the nation.
Okay. Ma'am, did you have anything you want to add?
Nothing to add, except I thought I saw that AUSA does have a special session on the vaccine response. Over, for those that are interested.
All right, thank you. So the next question that we have is, we recently learned that the Centers of Disease Control and Prevention, CDC, is recommending that people not use neck gaiters for prevention of COVID-19. If that is the case, why does the Army continue to recommend their use?
This has been one of my favorite questions because I think I've responded to this question well over 6 times in the last couple of weeks. It's an example of the poor information, or I think absolute misinformation that's out there. This all predicated itself on a study that Duke University was trying to develop a method for testing these types of cloth face masks. Even though there is a standard process that the National Institutes for Occupational Safety and Health uses to test these materials. So Duke University did that. They got a single individual, single neck gaiter, and tested it and said, oh, well, it doesn't look like it's too good. And then they were quoted as saying, wearing a neck gaiter might actually be worse than not wearing anything at all. That is false. And I will say that again. We have looked at this research. It was CCDC Chem Bio Center looked at this, actually did some testing about 2 months ago, and determined that the neck gaiters that the Army issues are as effective as any commercially provided cloth face covering. And then last week we got a pre-publication study by the National Institutes for Occupational Safety and Health, which did the same. And to give you some statistics, we've all heard about N95 respirators. Mm-hmm. N95 respirators block about 99% of the aerosols that a cough would produce. A procedure mask, in other words, a medical mask, typically they're blue, they fit over your ears, blocks about 59%. A 3-ply cloth face mask blocks 51%. A polyester neck gaiter blocked 47% when it was a single layer, and 60% when it was folded into a double layer. And in contrast, a face shield, you see some people wearing face shields, block 2% of the cough. So a double folded neck gaiter is actually superior to a medical procedure mask and just under an N95 mask in terms of protection that it offers individuals around someone who might cough while wearing it. So that's one of the reasons the Army continues to recommend their use. This information has been provided to the CDC, and we anticipate the CDC to change their official guidance in some amount of time. It takes a while sometimes to get things to change on websites.
Got it. Ma'am, did you want to add anything?
Yes, I just wanted to reinforce that masks have emerged as a critical science-based tool for slowing the spread of COVID-19. And while the study used the term that Mr. Resta spoke of from Duke, used the term neck gaiter, they didn't define the material. And so the issues, if you look on the CDC website about the mask, is the proper fit, that it covers the nose and mouth, that there are no gaps, and that it tucks under the chin. A neck gaiter made of the appropriate material as studied by the Army and as issued by the Army meets that bill and fits, answers the mail. So I would strongly recommend that the viewers look at all of the literature and not just run after a soundbite, and continue to use the non-pharmaceutical interventions against COVID-19, such as masks. Over.
Thank you. Next question, sir, is what's the Army's capability for testing its people for coronavirus?
The Army has coronavirus testing capability at many, if not most, of its medical treatment facilities for diagnostic purposes. For those places where they do not have their in-house capability, we have both a network of supporting laboratories. We have 9 large medical treatment facilities that have laboratories, and we also have a very, very ample laboratory support contract. At the same time, we are developing within the Army Public Health Laboratory enterprise capabilities for surveillance for COVID testing versus diagnostic. We currently have 3 of the 7 laboratories up and running at Public Health Command Europe and Law School. The Army Public Health Center here at Aberdeen Proving Ground, and as of last week, the Public Health Command Atlantic at Fort Meade. We anticipate having our laboratories at Public Health Command Central at Joint Base San Antonio, and Public Health Command Pacific at Joint Base Lewis McChord, hopefully Hawaii, Camp Zama, Japan, and Camp Humphreys, Korea, coming online all over the next few months to help with our surveillance.
Thank you. Ma'am, did you like to add to this?
Nothing to add. Thank you.
Next question. Does the Army have enough COVID-19 test kits?
Yes, we do. We manage our test kits at each individual testing location I think it's on a daily basis. We have an automated dashboard that tracks it, allows us at the headquarters level to track that. We have very good supply chains. Where we end up having problems, we'll end up, if one location starts to run out because they're running a Gene Expert versus a Hologic Panther or Panther Fusion or Cepheid or something like that, then we will ship kits from one location to another location to make sure that we don't run out. We also have priorities going on so that we make sure that we always have enough supply for diagnostic testing, and that's a higher priority than any type of surveillance or screening testing.
Okay. Ma'am, would you like to add to this?
No, sir.
All right. Next question. Does the Army have enough personal protective equipment, PPE?
Much like test kits, we manage this at the individual location and report it and make sure that we do not run out of this like we were concerned about earlier this year. And so at this time, we don't have any concerns over personal protective equipment. We think we have enough. And we're prepared if we don't have enough at one location, we make sure that we get it from a location that might have a little bit more that they can share, or we can consult with the National Stockpile or other places to buy it in the end.
Tracking. And we've got one more. We got two more questions. What are Army medical facilities doing to assess a patient suspected of having COVID-19?
And I was going to defer to Dr. MABY for that. This is a patient care issue.
Okay, let's transfer it.
I am not a physician.
Tracking. There you go, ma'am.
Thank you for that. So the providers in the treatment facilities follow standards of care for patient testing for COVID. And again, as Mr. RESTA said, diagnostics are the priority use of COVID-19 testing. There are many resources that the Army has published, a DoD COVID practice guide, pharmacy guidance, supplemental guidance, and DHA guidance. And this is available through our MilSuite site for the health providers to refer to. Additionally, we have many public health and infectious disease experts who can be contacted locally at the facility or through teleconsult to assist in managing a COVID-19 patient. So we have great diagnostic screening guidance and capabilities and treatment and care programs in place. Over.
Okay, thank you so much, ma'am. And the final question that we have on the panel here is, what are Army medical facilities doing to see or report potential COVID-19 patients?
What we do on that is that if any individual that is a beneficiary of an Army medical treatment facility has concerns regarding whether or not they are ill, they are encouraged to actually call their providers first. If they meet case definitions, they'll be requested to come in where they'll be tested in accordance with clinical practice guidelines. And if they are confirmed, they will, assuming that they not have severe disease, they will be recommended to go home and isolate while they recover, keeping in regular touch with their medical provider. For any confirmed cases, whether those confirmed cases are part of a diagnostic test or those confirmed cases are detected during a screening or surveillance, are reported to the local public health authority in the area that medical treatment facility is located. They are also reported through the disease reporting system internet, DRSI, which is what we use to track the outbreak across the world. And so we have pretty good data on who fell ill, who was reported over the weekend, for example, already today here on Tuesday, even though we did not require reports coming in on Saturday, Sunday, and Monday. We still have those data there. And so we follow all of that. Those data are then rolled up and sent up through Headquarters Department of Army to the Department of Defense, and the Department of Defense compiles them and shares them with the White House Task Force as well, so that everyone has visibility of what the situation is within the Department of Defense in terms of our current confirmed caseload.
Awesome. And ma'am, would you like to jump in on that question as well?
So I would speak as a user, because the system is Mr. Resta's and his teams, and it's been so important as a way to be able to capture what we see on the ground and send it up so that the Army leadership can see where the hotspots are and focus those assets, as Mr. Resta spoke of, whether it's testing or PPE assets, depending on where the hotspots occur. So it's a great system to see all of the Army and follow the trends and in this pandemic and in all the infectious diseases that we report through this system. Over.
Thank you. Thank you so much, ma'am. And the viewers are actually sending in a couple of questions. We're going to choose a couple of them so that we could, I guess, address their questions as well. We got one coming from Mr. Crit Peterson asking, can you get those slides? Mr. Peterson, on the Army Medicine YouTube page, this is actually being live streamed, and you can actually go back on that YouTube page and see the questions and see the slides there themselves. So if you're kind of astute when it comes to tech, you could go on YouTube and actually see the slide presentation information there as well. He does have an additional question. The additional question he had is, from an Army public health point, do you see military schooling, NCO academies, officer academies, and CDC training environments as a potential spread locations?
If we had not done something about it, the answer to that would have been yes. That is something I am probably, one of the things I'm the proudest of is that when this outbreak first started, our leaders decided, I think rightly so, to take a pause. And we put all of our stuff in hiatus for a couple of weeks, maybe as much as a month, while we figured this out, and came up with what I think are model programs in terms of reducing the risk. What they include is new entries into military training, essentially are, we say restriction of movement, we could call it quarantine, but they are brought together and into small groups and held there for 2 weeks. They are tested upon arrival to determine, are they bringing an active infection with them. They are then subsequently tested before released from their restricted of movement to make sure they have not contracted an illness, an infection while they were in there. They're issued masks. We train in small groups. We're not doing unit runs much larger than a platoon anymore. No big division is running around. And similarly for classroom training, we are trying to restrict it to make sure that the classrooms are not consolidated. And so now I can tell you how many people can fit into a classroom in order to maintain 6 feet distance in between. Essentially, you take the square footage of the classroom, you take 1/3 off for the instructor, you take 2/3, you divide that number by 30, and that tells you how many students can be in that classroom, because a 6-foot circle around each student is just a little over 29 square feet. And so we've applied those standards to our training. And we also require that students inside classrooms are required to wear masks. And so far we've done quite well with the number of individuals who have come through our training. We've had cases, I don't want to minimize that, but those cases have been in the hundreds in terms of outbreaks, not in the thousands, certainly not in the tens of thousands, as we have seen in broader communities or in universities and the like. So we're pretty proud of that, but we don't want to become too complacent about that as well. For combat training center environments, we are screening all soldiers prior to a CTC rotation. If they have a confirmed infection, they get isolated for 2 weeks, and if the deployment happens while they're in isolation, they're staying home. We'll also have the ability to test during the CTC training environment, and we have been very fortunate in that regard that we have not had any large-scale outbreaks at all in any of our CTC environments.
All right. Well, sir and ma'am, just for a limitation of time, we'll stop the questions there. And I just want to say, thank you for coming and participating, sharing this wealth of knowledge. The Office of the Surgeon General, Lieutenant General Dingle, thanks you for your participating in our live panel. And we want to thank the people who sent in the questions. We want to thank everyone who had a part to play in the preparation of today. And I want to say to you both, thank you for coming and participating.
And I just want to do another shout out. If we have any of our public health emergency officers who are listening, I want to thank them. Our success is rested upon their shoulders. And whatever success we have had is due to their activities. And so thank them, and I thank you for your service in that regard. And I'll thank Colonel Mabey as their representative for this, because without effective public health emergency officers out at every one of our installations, we would have had a heck of a time with this.
Got it. And we want to thank Colonel Mabey. Ma'am, did you want to send any shout outs here?
I just want to thank all the soldiers and their families and the supporting civilian staff for allowing us to continue in our fight against COVID. And our response to this virus will mature based on the data as we move forward. And I look forward to another forum where we can educate you as to how conditions are changing on the ground and what our response is at that time. Thank you.
Absolutely. And I want to implore onto you both, if you have the opportunity, share this podcast that we're doing, share this live stream recording to friends who may not necessarily even be in the medical field. This is information that generally we have, we would like everyone to participate in this discussion. And we really appreciate the time as far as the questions, etc. So thank you very much for participating.
Thank you.
And if you could both hang out in the broadcast room, I'll give my closing remarks.
Okay.
All right. And so everyone, thank you for participating in this COVID-19 panel that we had here. Really good information that was being shared to the public for you to consume regarding COVID-19 and Army's response to COVID-19. And as we say every time here in our panel discussion, Army medicine is Army strong.